Two. I don't think there's any. I think it's.
No.
Okay, there we go. All right, welcome everyone. We're going to go ahead and get started with our session on ILCOR hot topics from our task forces. We're just in the middle of getting our online Slido operation up, but I'll just introduce myself. I'm Bob Newmar. I'm one of the ILCOR co-chairs from the United States, and Tino Grief is my co-moderator here.
There's no grief in Greif.
Right.
Tino Greif.
Yeah, and you know, one of the purposes of this session is sort of to try to give updates on some of the recent work of ILCOR and some of the ongoing work of ILCOR. Over the past several years, we've evolved from sort of an every 5-year process of posting consensus on science and treatment recommendations to a more continuous process where we publish annually updates on certain topics, but also we have ongoing work throughout the year, and we will, as soon as that work is done, and as soon as a consensus on science and treatment recommendation is finalized by the task forces, it gets posted online for public comment, and that happens continuously throughout the year, and then that gets culminated in a once-a-year publication. So the purpose of this presentation here today is talk a little bit about some of the recently posted consensus on science and treatment recommendations that are of interest to all the people involved in cardiac arrest resuscitation, but also some of the ongoing work of the task forces, and perhaps a little bit of a preview of some of the upcoming recommendations that you might be seeing soon. So with that, I don't know, Tino, anything else you want to say to introduce the group?
No, so there are still some places maybe. Oh, this is mine. Shit.
Yeah, we have.
So for you, there's a place here. Yeah, the lady in red, especially for you. Here, yeah, sure. Okay. They are still working on Slido, so don't be surprised if your messages or questions don't come through, but it will be solved. We'll start immediately with very short, as a rapid fire sessions. The first, it's not always basic life support. Janet Brave, a long way from Australia, a professor also, and she will present us a little bit what the BLS group is doing. Janet Brave took over this task force a year ago, more or less.
6 months ago.
6 months ago. Great work over the last 6 months. The floor is yours.
Thank you, Tino. Do my slides just come up? There we go. So I'd just like to start by saying, look, I've only been part of the BLS task force for 6 months, and I've been thrown in the deep end as chair, but I'm pretty confident that you don't need to learn to break dance to do CPR, okay? I think those guys, there was quite a bit of pause in that dance room. So yes, I am from Melbourne, and I'm absolutely delighted to be here in Antwerp where it is warm. It's been pretty cold at home, and it's so delightful to be able to travel again and for us all to be together again. So thank you for this invitation. I do have some conflicts. I'm an associate editor on Resuscitation Plus, a board member on Resuscitation, and a member of the Australian Resuscitation Council. Oh, already gone too far. So these are the real stars of the BLS task force. Teresa just gave an incredible Sapphire lecture, and thankfully she's staying on to guide me through these early steps of the meeting of the task force. We do also have now like a really excellent international representation on our task force with new members from South Africa and Sri Lanka. It does make our meeting times very difficult to coordinate because what is 8 a.m. in Melbourne is I think 2 a.m. in Sri Lanka. So we are trying to work through that, but these are the real superstars of this work. And most of them, there's quite a few of them here at this meeting today, and I encourage you to go and see their talks. We already saw Teresa, and she's presenting now in the diversity group. And I would just like to really highlight this talk here. Helps if I point up there, not down there. This one from Ziad. This was actually inspired with Ziad's new to our task force, and it was actually an inspired talk by our minimising pause treatment recommendation. He went and looked at their VACAR data and came up with this abstract pretty quickly. So that's a really exciting one, and it's great that he's in the best of the best. So I encourage you to go and see that. So our current group of a huge number of reviews that are coming out quite regularly. You will note that on the CoStar, the preprint CoStar that's already presented on the ILCOR website, and the ones that are coming out, they're all coming out around drowning at the moment. This was a layover from last year, and it's pretty. It's very important to Australians that we get this right. This is Bondi Beach, where we have every day hundreds of tourists going straight from the airport to this beach and drowning because they come from landlocked villages, or they can't swim and they don't know what a rip is, and they get dragged out. The task force has been really fascinating for me though, because we're coming up with some concepts around cold water and things that I wouldn't have thought of, because we don't really have ice cold water in Australia. So it's been a real international effort, these treatment recommendations that are coming out. Unfortunately, they're not based on a whole lot of evidence. There's not a whole lot of evidence out there on drowning, sadly. So if any of you want to do a PhD, please do it on drowning. We really need some high quality evidence on drowning, if anything else. There are, however, some individual animal case studies of drowning and CPR working. These won't make it into our treatment recommendations, but I thought they were fantastic. There's this guy blowing into a fish and it was swimming away. So this is our latest hot topic. We've decided to look at PPE, see the impact of PPE on CPR quality, and you'll note that that's our fearless leader here, and doing it ALS, not BLS, but I couldn't help but put that up. So we've chosen to do this. There's been a couple of systematic reviews done last year on this, and we had a look at those thinking we might be able to do an allotment of those reviews, but we found that a few of them have some methodological problems, and there's been a few studies published recently, so we've decided to redo this. And we're going to do it first on the overall impact of CPR quality, and see if there is an impact, first of all, because the systematic reviews that have been done have some suggestion that it may impact on compression depth. And then we're going to look at, what different interventions people have used, such as changing rescuers a bit more frequently. Technology is massive at the moment in BLS, as you all know. This is hot off the press, published in Current Opinion in Critical Care from our very own Federico and Tomaso. This is actually hard to get a copy of at the moment, so if anyone wants a copy, my email's at the last slide. I'll send it to you. But it's a really fascinating read and a good coverage of technology right across from dispatch right through. So dispatcher recognition, we've decided, even though this review was last done in 2019, we've decided to have another look at this, because there's a lot of technology that's been happening in this space. There's been machine learning trials and observational studies. Unfortunate for Freddie Lippert, that JAMA machine learning trial showed no difference, but the machine learning application was superior right across the board in terms of out-of-hospital cardiac recognition. It just didn't show a difference because the dispatchers didn't always use it. Smartwatches, can we detect, can we improve recognition with those, as well as, having a Google speaker in your home, and also video dispatch. So that would be a really good one to move forward with. We have decided to move away from a few systematic reviews that we were going to do and make them scoping reviews. So scoping reviews don't really allow you, unfortunately, to have a treatment recommendation, but they will help us direct our questions better. So, what elements should we be actually looking at rather than doing a sort of more broad scoping look, and is there enough evidence to want to even do a systematic review? So we're doing a scoping review on feedback devices, and this is real-time feedback devices on CPR quality. I think I wasn't part of the last review that was done on this, but there was a lot of crossover between feedback devices in real-life CPR versus training and how you untangle that. It was quite messy, and I think a lot of those studies that involved training got excluded because they wanted to do a pure study on feedback devices in real time, and it ended up being too small, and the task force were pretty unsatisfied. So we're going to do a scoping review to see whether or not there are more specific questions that we need to be looking at here, such as smartwatches and things. CPR instructions, dispatcher CPR instructions, this is something that I'm pretty passionate about. We've done quite a bit of work on this space with Judith Finn's group in Perth. And we've decided to do a scoping review here because why should we bother even looking at, does it work? We know it works. So we've moved on from that to now looking at what elements of it might work. So we're going to do a scoping review looking at, does it matter how you describe compression depth to, does it matter how they describe compression depth down the phone to someone? And also, this is the linguistic studies that are coming out of Perth are amazing. They've discovered that depending on how you ask the question about performing CPR, you get a completely different response and bystander CPR. So, if you command it, like we're going to do CPR, you get a really high bystander CPR. If you ask them, do you want to do CPR? Very, very few. So we're going to untangle all of this in this scoping review, hopefully. And then there's drones. You might have seen this paper, this case study of a 77-year-old man, published in the New England Journal. I think it was this month, maybe even. It does have a fantastic video of the drone delivering it, but because I'm technologically, I'm terrified of using videos because they never work for me. So I just took these stills of it, and you can see here. Let me just put this on. So this is the cardiac arrest up here. This is the drone dropping the AED and the man coming over to get it and taking it back. It's got footage of it going over the houses to get there. It's quite pretty because we don't see snow, so I just got to see some snow as well. It was unfortunately hard to put his good neurological outcome down to the drone because an emergency doctor happened to be driving by and did CPR on him. This guy had an unbelievable chain of survival. He had an emergency doctor drive by and do CPR. He had a drone deliver an AED. He got a shock. He got TTM. And he went to the cath lab and went home, I think, 3 days later or something. It was just an unbelievable story. So we're planning on doing a scoping review of drones to sort of see, is there enough evidence out there to have a look at this question. I know that there was a paper published recently in Resuscitation that looked at response times too. So that's a really exciting one too. And I think that might be my last slide. Yes, so there's my email. We have been asked to perhaps, if you've got something that you think that we need to be looking at on our task force, to email me, but please, not everyone in this room. And I may not get back to you, but I may take it to the task force. So thank you. And it's great to see so many people here.
So I think we have time for, yeah. And I think we might have time for maybe one question or one suggestion about sort of some topic to review from the Basic Life Support Task Force.
I've covered it all too well.
Good. All right, so if we have time at the end, we can always come back and bring some questions forward. So thank you very much. So I have an announcement. So if it's too crowded in here, if there's people outside the door, people can go to the Gorilla Room upstairs, and they're live streaming this event up there. So if people prefer to sit down instead of stand along the wall, that's one opportunity. Good. Okay. So I'll go ahead and introduce our next speaker. So next up we have Dr. Catherine Berg, who is leading our ALS task force, and she is the Associate Director for the Center for Resuscitation Science and Pulmonary and Critical Care Physician at Beth Israel Deaconess Medical Center in the Harvard Medical System. So welcome, and we're looking forward to your presentation.
Thank you. Thank you for having me. I flew in from Boston yesterday. Both this morning's first session and Janet's talk just now have reminded me that I need to go back to remedial school for making my slides more visually interesting, but I'll do my best. I'm going to focus mostly on the things that we put out for 2022, and then at the end we'll talk a little bit about what we're working on for this coming year. Conflicts, I do have a compensated role as a co-editor for the annual COSTAR summary, and then some volunteer roles at AHA and ILCOR both. I also forgot to put here, I'm on the editorial board for Resuscitation Plus. So for 2022, just the three systematic reviews that resulted in new treatment recommendations were temperature management after cardiac arrest, and I'll try to skim past that one because there's a dedicated session on this topic later today. Point of care ultrasound specifically as a diagnostic tool during cardiac arrest, and then the combination of vasopressin and steroids during cardiac arrest. So for temperature management, and this has clearly been, one of our hottest topics, pun definitely intended, this year. Clearly the TTM2 trial that came out last year triggered this review, and also we had the 2019, I believe, trial in France, also looking at both trials really comparing hypothermia to normothermia with somewhat different outcomes and in different populations, and then the systematic review done on behalf of the task force that informed this COSTAR. And this, our main take-home and the main change in recommendations was to recommend a strategy of normothermia for most patients, and that came, really this is kind of the probably most key summary table from the COSTAR of the 6 randomized trials that have looked at comparing an approach of hypothermia to normothermia or fever prevention, and that overall in meta-analysis did not show any difference in outcomes. And so those treatment recommendations were to target a temperature of less than or equal to 37.5 for patients who are comatose after ROSC from cardiac arrest. We put in this caveat, this sort of secondary statement that whether there are still subpopulations that might benefit from a hypothermic strategy remains uncertain. And this, as I'll talk more about later today, generated a lot of discussion in the task force. And then that patients who come in and are mildly hypothermic on their own, that we recommend not actively rewarming them. And it's a good practice statement in acknowledgement of the fact that that's expert opinion and not based on any evidence. And highlights of the task force discussion around these new recommendations were, there was a lot of discussion around whether there might be some subpopulation that does benefit from hypothermia, if that's people that you can cool sooner, or certain rhythms or certain etiologies of arrest, different downtimes, things like that. And whether there was a lot of concern that recommending normothermia might be interpreted as recommending no temperature control, and could that worsen outcomes inadvertently, since we did see a lot of changes in the practice around temperature management after cardiac arrest after the first TTM trial in 2013. And then again, whether the problem was that we were not delivering this intervention soon enough, and if that's why we haven't been able to see a benefit. So the next review was point-of-care ultrasound as a diagnostic tool during cardiac arrest, and I think ultrasound use during cardiac arrest, at least in my center and many centers around the US, I would say is one of those things that has gained hugely in popularity without a huge increase in evidence that it is helpful. So Josh Reynolds led this systematic review. He also did the prior one from last year, looking at point-of-care ultrasound as a prognostic tool during cardiac arrest. And in both cases, there are lots of studies, but when you actually try to look at those studies and whether there are comparator groups and how systematically they're done, they are extremely heterogeneous across studies and very hard to interpret the results. He found a single study of 48 patients that was actually provided enough data to calculate sensitivity and specificity. And so our recommendation is really based on that one study. And because mostly of that paucity of data, we recommend against routine use of point-of-care ultrasound during CPR to look for reversible causes, but suggest that if it can be done by an experienced person, and you can do it without interrupting CPR, then it may be useful if you're suspecting a particular cause of arrest, that ultrasound can be useful to diagnose. And then kind of a cautionary statement, again, a good practice statement, that if you're considering using ultrasound, you really have to weigh that against the risks of interrupting CPR. There are several studies out there showing that when point-of-care ultrasound is used during cardiac arrest, that the pauses in CPR tend to be longer. And also that you need to make sure people aren't misinterpreting sonographic findings. So for example, I know there's data in pigs from cardiac arrest that the signs of RV strain and things that people in the non-cardiac arrest setting can point you towards a pulmonary embolism is much less specific for that in the setting of cardiac arrest. Discussion highlights here are really just that, again, we know this is a popular modality. There's a lot of sort of intuitive reasons we think it could be helpful, but the evidence really doesn't support it. So any researchers in the field, I encourage you to do some high quality studies on point-of-care ultrasound during arrest. And again, just a cautionary note about the harms of pausing CPR. And then our last review that gave us new recommendations last year was on vasopressin and corticosteroids for cardiac arrest. And this was a systematic review that was kind of triggered by a trial led by some folks on the ALS task force and others. And they, with their group, did a systematic review on this topic, and we did what's called an ad-allotment for ILCOR, which is when you take an existing systematic review, you make sure it meets all the ILCOR criteria to be rigorous enough to generate a co-star and new recommendations, and we used that. So there were two earlier trials in 2009 and 2013, both at a single center in Greece, and this more recent one done in Denmark. And basically, the older trials showed improvement in both ROSC and survival and neurologic outcome with the intervention of vasopressin and steroids. The newer trial did find an increase in ROSC, but did not find any benefit for the survival outcomes. And in meta-analysis, that's also what they found, that looked like more ROSC, but no survival or neurologic outcome benefit. And based on this, and there was a lot of discussion around how much you weight return of spontaneous circulation compared to survival and favorable neurologic outcome, and the fact that the older trials that had some differences in design compared to the newer trial, and they were the only ones that showed the survival benefit. So in the end, we suggested against the routine use of this drug combination for cardiac arrest. Slightly different wording for in-hospital cardiac arrest and out of hospital, because all those three trials were done in the in-hospital setting. But in general, basically the same recommendation. And again, we talked about weighing survival versus ROSC. We have in the past made recommendations in favor of some drugs, notably things like antiarrhythmics for refractory shockable rhythm, that were based on trials that did not show an overall survival benefit. And we discussed whether we were being inconsistent potentially here, but in the end decided that those trials did show survival benefit in some subgroups of patients. And that was not the case in the vasopressin steroids meta-analysis. So we decided to recommend it not be a routine part of practice. And also just to point out that the earlier studies also included post-ROSC steroids for people who got ROSC and were in the steroids arm, which the newer trial did not. So things that we're working on now, we are updating our review on eCPR, and I'm sure as you all know, there's the ARREST trial out of Minnesota in the United States that showed a strong survival benefit from eCPR for patients with refractory shockable rhythm. There's a more recent trial from the Czech Republic that many of you in this room probably know more details about this trial than I do, but was stopped early for futility, although it was a p-value of 0.09 for what looked like a potential benefit. So I'm not sure of the full story about why that trial was stopped early. We're also looking at double sequence defibrillation, because there's a trial that is kind of close to completion now and should be out this fall. Calcium during cardiac arrest, treatment of seizures after return of spontaneous circulation, and that review was triggered by the TELSTAR study. And then prognostication of favorable neurologic outcome, which will be an ad-allotment of a systematic review that was done recently. And I'd like to thank all the ALS task force members, and thanks for having me.
Maybe one question. We still have time maybe for one question from the audience. On the internet, we don't have anybody.
Yes.
What are the projects you are currently working? Are they running scoping reviews or systematic reviews?
Yeah, so the list that I put up on my last slide was the systematic reviews that are currently in process. Yeah.
Okay.
So one question that might be isn't in online question, but I've heard from others is relying on ultrasound. Was there any part of that review that looked at transesophageal ultrasound and what the potential is for that relative to transthoracic ultrasound?
Yeah, so actually several of the smaller studies so some studies combine both. They look at ultrasound usage and they include, some of those patients get transesophageal. It's been proposed that transesophageal might be more a better choice because you don't need to interrupt CPR. It can be kind of a continuous visualization. Obviously, not all centers are going to be able to implement that, and it's a lot difficult in the out-of-hospital setting. But so I don't think there's enough data really to have separated the two.
More data is needed.
Definitely, yes.
As usual.
Okay, thanks.
Thank you.
Our next speaker is Barney Schollfield, a clinical scientist and honorary consultant in pediatric intensive medicine, and we should have him online. I hope this is working out.
Good morning, Tino.
And
Good
here he
morning,
is.
Antwerp. Can you hear me?
You're perfectly.
Thank you, Tino. Thank you, Bob. So I can't see you, but I'm sad to be missing what sounds like an absolutely brilliant time in Antwerp. So hello from a rather warm Birmingham. And it's my privilege to talk as the Vice Chair of the Pediatric Life Support Task Force on what we've been up to. I don't have any conflicts. I do receive some resuscitation research funding in the UK. Our group is led by KC. He's a pediatric emergency medicine clinician from Singapore, and this is some of our fantastic diverse group. KC follows on from Richard Aitken, who as a group and as an ILCOR family, we were sad to lose this year to a long-term illness. But a lot of the work that Richard Aitken and the New Zealand Resuscitation Council have given to us, we continue. But the Pediatric Task Force is tasked with everything to do with children outside the neonatal period up to adulthood, but of course has huge crossovers with a number of the other task force. So we have a busy time and we need a big group, and we're always looking for new members and new interest. Our kind of core work faces around what is very familiar to you, which is our kind of algorithm for resuscitation. So this is the PALS algorithm from the UK Resuscitation Council. And what the group does is to take this, and then we get out our sticky notes and we look at all the things in the decision making which has gone to develop this, and to look at all the questions which are available. And I know that all the task force do this, and it can be quite overwhelming when you realize quite how many nuanced things need to be answered. In the current COSTAR, which has been mentioned previously on the preprint, I can highlight the areas which we've already published on and we would love your comments on. So areas such as public access defibrillation, and I'm going to talk a bit more on that. But also things like the use of PEWs and early warning systems and their merits. And those were our two big systematic reviews back in 2021. We've had a number of evidence updates, and of course in pediatrics, we're slightly limited by the number of big clinical trials to really give juicy treatment recommendations. So we're continuously surveying the researchers and encouraging what evidence is out there to look at all these different elements. So we've looked at treatment for bradycardia and the use of transcutaneous treatment, as well as sequence-only chest compression and the use as we go down. I'm just going to comment on the public access defibrillation. So some really lovely work by Diane Atkins using the CARES registry from the US. And actually there was, although pediatric out of hospital arrest and the use of AEDs or public access defibrillation was small, there was a treatment impact. There was an outcome impact for the use of it, particularly in the age group over 1. So we have this recommendation which has come out and hopefully will influence the pre-hospital applications of public access defibrillation, even in settings where pediatric arrest may occur. We weren't able to make recommendations in the under ones, but that was purely due to the very small number of cases which we could identify in these registries. It's not that we don't necessarily think that there may be a benefit. So again, more research, more patients, we want to know if this is being used. And I think this will be an important topic to overlap with the BLS team. Of course, as with, I could put this slide up for every question, we need more studies, we need more understanding, and we need to also, with any of these technological advances, know how it impacts our original recommendations on bystander CPR and quality of CPR, so that we don't introduce one thing and actually start to do detrimental effects on the other. The other big evidence update that we did last year, following on from what Dr. Berg was saying about the targeted temperature management studies, was to look again in the pediatric evidence, what is out there. So our treatment recommendations haven't changed. We remain consistent with saying that in infants and children comatose following either out or in hospital arrests, we need to actively control temperature, and that is important with a temperature below 37.5. But of course, more research at both hypothermia levels as well as normothermia, optimal timing, duration, and techniques. And it's great that there is just to be started a big international study looking at duration of temperature management after children following the adult ice cap study. What was novel for us is to communicate that through the ILCOR website and then through social media. So this kind of evidence review for targeted temperature management. And it's just to highlight that following us on Twitter or following us on Facebook, the ILCOR site and the website will start to provide more updates and more real life information about as this evidence comes out. So as we move into the next year, we have a huge amount of work. Again, on the left-hand side, you'll see that these are the areas that we're looking at in the Pediatric Task Force following through that algorithm. Of course, on the right-hand side are all the special groups that we have. So the cardiac babies, the congenital heart disease, trauma, sepsis, and children with pulmonary hypertension. Just a quick highlight, ECPR has been mentioned. It's a big topic within our pediatric cardiac ICUs, not used in the out-of-hospital setting as much due to logistics and numbers, but very frequently instigated in our post-cardiac surgical programs. So evidence on its use, on its timing in the cardiac arrest setting, there's lots of data that we want to go looking at, as well as the adult evidence. There's building pediatric evidence, and there's a huge amount of work coming through the ELCO groups, and the task force is going to be looking much more deeper into that. I mentioned about our special populations, and our congenital heart disease population have a much higher prevalence of cardiac arrest, and so understanding whether we need modifications to the algorithms and special highlights for single ventricle populations. So we're going to be looking closely at the evidence for that and whether we need more bespoke algorithms in that group. Point of care ultrasound taught now to all our emergency medicine colleagues and taught frequently on our ICUs, but its role within pediatric cardiac arrest still remains slightly elusive, and checking that it doesn't cause harm, as Kate mentioned earlier. We will continue to look for that. And we have a big review ongoing following the work from Claudio Sandroni and the adult group. The pediatrics have taken on the look at all the neuroprognostication tools that we have to our disposal. So there's a big systematic review that hopefully we'll report in the next few months, and we'll build up on some much more definitive kind of clinical guidance for those in the post-cardiac arrest setting about neuroprognostication and both the timing and the kind of sensitivity and specificity of the tools that we have. We remain committed to kind of equality, diversity, and inclusivity within the group, both the task force as well as the populations that we're serving, and questions are arising, for example, around changes in resuscitation and monitoring devices in skin color, as well as the quality of care and access to treatment. So yes, ECPR may be accessible in certain settings, but giving valuable insights into when it's useful elsewhere remains important for the group. My final slide is just a little advert. So we're always keen for new members and new workers within these systematic reviews. The concepts of crowdsourcing systematic review team is building, and I would call on anyone in the audience and who's seeing this who has an interest in being part of evidence evaluation. There will be opportunities as we move forward to join members of the ILCOR task force in undertaking reviews. It's a great way to get into the science community. We'd like to hear from you. We'd like to know your areas of interest and your experience, and there will be possibly adverts coming out looking for people to join these teams. We remain committed to the ILCOR approach for children, and I thank you very much for listening.
Okay. Excellent. We do have time for maybe one or two questions. Any questions for Dr. Schofield?
I can't see everyone running forward, but
Don't worry.
Yeah, we don't have any questions in the room, and I don't see anything specifically on the chat. So we will go ahead and thank you, Dr. Schofield. We appreciate the presentation and your joining us virtually. Next up, we have Dr. Tino Greif from, he is representing our Education Implementation in Teams Task Force, and he's a professor of anesthesiology coming to us from Bern, Switzerland.
If I get my slides. I like this composition of the presentation because we had now 2 presentations with a lot of photos, very nicely made. I'm like Kate more a purist, so these are text slides. I have no conflict of interest. A lot of companies donated material for research, but I have some intellectual conflict of interest, and I forgot to say also that on this slide that I'm also on the editorial board of Resuscitation Plus. The task force, I'm honored to have a very nice and very hard-working co-chair, Adam Chang, because half a year ago, Janet was the co-chair. And then we had a transition, Adam jumped in really nicely. The task force has 15 other members, and the distribution is quite overall. We are 5 from the ERC, 5 from the Resuscitation Council Asia, 4 from the Heart and Stroke Foundation Canada, 2 colleagues from Australia and New Zealand, 1 from AHA. Unfortunately, nobody from Latin America and South American Resuscitation Council. On the other hand, as ILCOR started about a year ago to allow people with long-lasting working in the task force and the committees and emeritus status, we have still people there which bring in their experience into the task force, and they are mostly guiding new colleagues who are stepping in. And from this year on, there are also the positions of mentees. So if you are really interested into ILCOR, you could bring up your name, why you are wanting to do, and the mentees are applicants which are maybe not at the level to be selected, but with a lot of promising possibilities, and they might then step in as a full member. And also, there's a science and education, a science advisory committee on ILCOR, which oversees a little bit what the task forces are doing, and each task force has representatives in this committee, and ours are from Australia and the United Kingdom. Going back to 2000, we had quite a lot. The task force had quite a lot of systematic reviews. You see this listed here. And because I'm showing this was the basis for our guidelines. So from ILCOR comes the evidence, the very solid, elaborated systematic reviews, scoping reviews. Scoping reviews, as Janet said, are looking at the broader picture of what's out there. And we have also the last point is evidence updates. Evidence updates are looking into questions, what's the material there, and sometimes there's not a lot. So these evidence updates, if new studies pop up, can trigger a systematic review. If you send me an email, you get the slides. It's very easy. Last year, we had one systematic review driven by Janet about, and in one word, self-directed learning is a tool for resuscitation. And we did a lot of evidence updates. And you see this in blue. These evidence updates brought up sufficient studies to make either a systematic review or a scoping review. This year, and this will be published in October, we issued 4 systematic reviews, and 2 of them were triggered from the last year. One is the first one, the peri-arrest prediction of survival following in-hospital cardiac arrest. We looked at tools to predict survival for in-hospital cardiac arrest. And in summary, all the tools should not be used. They really cannot predict it. It's very hard to predict what's in the future. And we need more and better studies if we are going to do this. You might, and this is I might use these tools for having an idea which conversation should you do with your patient or the families about cardiac arrest. But it's a very weak one. The other was we should continue to teach basic life support for possible rescuers for high-risk population. That's a good thing. We have now very good evidence that if people attend a certified resuscitation course, patient outcome is better. We have solid data for adults, neonatal, a lot of data, and trauma. Pediatric, there were no studies, so we cannot say do it, but why shouldn't be this also good for pediatric patients? And finally, a new question was answered. Blended learning is very suitable for teaching CPR or resuscitation in general. A scoping review looked in faculty development, and this was not possible to do a systematic review because the studies were so diverse. But all in all, we should continue faculty development, which is a good thing. And some evidence updates were done for this year. Now, the other thing the task force did in the first month, we sorted out our questions, and the base for sorting out was a very nice publication in circulation, looking at this education part of the chain of survival, separating instructional design, so how are we going to teach, from faculty development, from the learners, from the person doing this, and the implementation part. And at the same time, this was a task by ILCOR, the questions were renumbered newly because it was a mess essentially, because nobody knew why these numbers were there. So we have now questions under the title of training population. So who is training what? We have faculty development and the knowledge translation and implementation part. And the fourth point is really instructional design. So how are we teaching resuscitation? At the same time, we looked at questions. In ILCOR, you have some questions, they are reposed, which means we don't think there are coming up new studies, but maybe in the future new important stuff comes up which we can dig them up and make them an active question again. They are screened, but not really working. We are not really working on this, and we retired some questions. And retired was very easy because we have to sort out new questions are coming in, all those are going out. Retired questions, for example, we know that team and leadership training is helpful, and it will be very hard in the future that somebody is going to do a randomized controlled big trial which would change the recommendation. That's always the point. Same for rapid response and medical emergency teams. It will be very hard nowadays in all these hospitals where we have these systems to have this kind of study telling us you should not do it. What are we working currently? And this is going into the next year. One systematic review is looking into the prevalence and if mandatory training has an effect. The family presence in adults is a long ongoing study, very interesting, a tremendous work. There was one in children, so we did one in adults, and I hope we can submit this soon. Yeah, fingers crossed. We have to look again into cardiac arrest centers. A lot of new studies were out there. Cognitive aid during resuscitation training, education, so what is helpful. Interesting, in a scoping review we did beforehand, we figured out that, for example, cognitive aid during real-time CPR, specifically in the basic life support, prolonged the procedures because people are reading what they have to do, not doing it. The other ones are stress and cognitive load. and stepwise approach to skills teaching, which is an important issue for the European and Australian teaching system. A scoping review is going on if what's out there on frameworks for teaching laypersons, and looking out what's on virtual reality and augmented reality for resuscitation teaching. We will not do a systematic review because the studies are so different that it's very hard to compare them. And we will also do some evidence updates. With this round, all the questions in EIT had at least once a systematic review, scoping review, or evidence update. What's also going on, we are working on an ILCOR task force statement. Statements are issued in a far broader way, looking what can we do to address specific problems. And the problem here is resuscitation in the low resource settings. We won't give a guidance or a recommendation for low resources. We are looking together with representatives from these areas. We invited a lot of people to look what has to be changed something in resuscitation, what are the possibilities, and out of this statement maybe then we can extract a recommendation for certain areas. So that's the function of a statement. In summary, the task force changed a lot over the last 5 years. This year, the last 5 long-lasting members, some of them were over 10 years, are moving out and going hopefully into the emeritus status. There will be a call very soon for new members, so at least in EIT there are 5 positions open, so if you are interested, apply. We need you. And this is then a ranking simply on your achievements and diversity and where you are from, so it's a rather hard job to sort this out. We have therefore a smooth transition in the task force for the preparation for the maybe other Big Bang 25 stuff to guide what's going on in education. For the year after 24, I want to have an update on all questions to trigger the 25 cycle. And with this, it's really the call also on you. We as a task force, we need your questions, your problems to figure out, can we do on your question a systematic review, a scoping review, or an evidence update? Because what we are doing is going back to the Resuscitation Council for making their guidelines. And if we don't get your questions, we are working in a kind of international, high-level, nice point in time. So bring in your questions, and that's all at the end.
Yeah, just go ahead and introduce Helen. We have 15 minutes left.
And because time is running out, we are going to the next speaker, which is Helen from Australia. And if I get this on, here it is. Yeah, here she is also a professor and researcher in Australia, professor of neonatology. And Helen, we see you with a very nice background. But we can't hear you.
Right. Good point. Thanks for that. Thank you very much, Tino. Not to forget the microphone. So yes, I live and work in Brisbane, Australia, but I'm actually greeting you kia ora from Auckland, New Zealand, because I'm over here on leave at the moment for a week too, which is rather wonderful, but it's cold here. So anyway, I wish I was there in Antwerp. It'd be a lot warmer. Just going to share my screen. Great. So yes, I'm the chair of the Newborn Life Support Task Force and also the convener of the Neonatal Subcommittee for the Australian Resuscitation and the Australia-New Zealand Committee on Resuscitation. I have a very fledgling member of the editorial board of Resuscitation Plus also, but I don't think I've got any other significant conflicts of interest with respect to this presentation. The Neonatal Life Support Task Force is also very diverse. From all over the world. We've been missing seeing each other face to face, and this photograph was taken of our former chair, into whose very large shoes I've had to try and step. That's Myra Wyckoff from Dallas in Texas, and Jonathan Wiley, who many of you will know from the UK. This meeting is taken at the ILCOR meeting in Cape Town in South Africa, and I use it as evidence of just the extent of international collaboration and consensus we achieved, because that meeting happened to coincide with the final of the 2019 Rugby World Cup, and the Australians and New Zealanders on the committee and the others from all over the world managed to persuade everyone that we needed to be Springbok supporters, at least for a day. We're also very lucky in the Neonatal Life Support Task Force that, due to the previous leadership of Myra and Jonathan, and before Myra, Jeff Perlman, we've actually built up not only the task force and the 17 odd members of that and a handful of emeritus members of the task force, we've also built up a content expert group of about 40 additional people from around the world who comprise people who've rotated off the task force, people who are interested to join the task force in the future and want to learn how we work and what we do, and other people that we've tapped on the shoulder because of their specific content expertise. And we try to meet face to face twice a year. More in the last couple of years, obviously, we've had to do that virtually, but that additional 40 or so people from around the world have been a wonderful resource for us, and we're very grateful to them. So neonatal resuscitation has been described by some very clever colleagues of ours as a common and important intervention. When I say common, I think we often like to observe that the day of your life on which you're most likely to need some form of resuscitation is in fact the day you're born. It can also be a stressful and sometimes chaotic experience because newborns are renowned for having difficult airways and problems with vascular access. We have very limited measurement devices designed and purpose-built for this important group of patients. We don't really have very good biomarkers that predict the future for these babies. They have some very unique vulnerabilities based on the fragility and early stage of development of their tissues and organs. And importantly, our resuscitation efforts tend to work, but when we don't do them perfectly, or when when interventions have adverse consequences, we measure the effect of those consequences in many decades, maybe nearly a century for some of our patients. So it's very important that we get it right. The other thing about newborn resuscitation is that it takes place in the setting of the most dramatic change in physiology that occurs at any time during life, which is the change from placental-dependent gas exchange and intrauterine life to air breathing and extrauterine life. And it's against this very dramatic change, which takes place over the minutes and hours after birth, that we need to intervene to help those who are having difficulty with that transition. There are some enabling factors for research. One is that the babies in difficulty are relatively frequent. It's estimated that about 10% of all newborns need some sort of intervention to help them make that transition. Increasingly, the subsequent neonatal ICU care is standardised and evidence-based, and so in terms of trying to measure the outcomes of what we do, then variability in neonatal intensive care is, I would say, becoming less of a problem. Most neonatal services have methods and systems in place for follow-up that are already well established. And we've got some very good national and international networks, collaborations, and some reasonably large population-based or databases that we can utilise. So the newborn life support algorithm looks quite different from the other resuscitation algorithms in that it begins with a lot of things that might not be routinely considered as resuscitation, things like, keeping the baby warm, drying the baby, stimulating the baby. But the aim of resuscitation of the newborn is generally to assist with the adaptation from fetal to extrauterine life. And very often these early measures actually work and make the difference as to whether you need to move down to the things at the sort of pointy end of the resuscitation algorithm, such as breathing support and chest compressions and drugs to support the circulation. So newborn resuscitation doesn't usually start with an asystolic lifeless patient, but sometimes it does. And establishing lung aeration is considered and effective ventilation is considered critical, and there seems no point in starting chest compressions without it. And when ventilation is adequately achieved, then very often cardiovascular support is not needed. The other issue, though, with newborns is that there are risks in doing too much as well as doing too little. So in terms of starting with the prevention side of things, one of the topics that's achieved a lot of interest in recent years is the timing of the umbilical cord clamping and the management of the umbilical cord. The reason why this is so important is that during the transition from intrauterine to extrauterine life into air breathing, there needs to be about an 8 to 10-fold increase in pulmonary blood flow as the lungs are aerated, and to achieve VQ matching in the lungs. Deferred cord clamping enables the lungs to fill with blood from the placenta rather than retrograde across the ductus arteriosus from the aorta. And very well-conducted animal studies convince us that this can have potentially critical effects on systemic coronary and cerebral perfusion. So there's been a lot of interest recently in trying to get this issue of umbilical cord management right. To that end, the Neonatal Life Support Task Force conducted 2 very large multi-comparison reviews of various methods of umbilical cord management in 2019, and they compared early versus late or deferred cord clamping, so-called cut cord or intact cord, milking or stripping, and we conducted separate reviews for preterm babies and for those who are at late preterm and term gestations, because of some important differences in their physiological responses as well as the critical outcomes. So we found evidence for deferring cord clamping, although for most outcomes that was of low to very low certainty. There's also a possible role for intact cord milking in infants of greater than 28 weeks gestation, but some concerns about an increased risk of intraventricular hemorrhage, a serious, sometimes catastrophic complication in preterm infants that we need to worry about. For most of the comparisons that we tried to do between different methods of umbilical cord management, there was insufficient evidence. And importantly, many of the trials had specifically excluded infants who were deemed to be at particularly high risk of needing resuscitation. So there is still a gap in knowledge with respect to what to do for the baby who does appear lifeless or in real difficulty right at the moment of birth, and whether delayed umbilical cord management should still be practiced, or whether indeed there are strategies to conduct resuscitation while the baby's still attached to the umbilical cord and the placenta, which is still adherent to the uterine wall. So the important thing about this is that the field has been moving reasonably fast, and we need to already make plans to update both of these reviews. For the late preterm and term review, this will probably be a systematic review next year, although we may conduct a scoping review for that one. For the preterm review, we're in discussion with Cochrane Neonatal, who served as a knowledge synthesis unit for both these reviews and worked with us in 2019, and with the so-called ICOMP collaboration about a strategy for conducting these, the preterm review update, aiming for 2023. ICOMP is a very substantial individual patient level network meta-analysis and also study level meta-analysis involving most cord management trials that have been conducted to date in preterm infants, and it's led by investigators at the University of Sydney. So another topic that we are really interested in, even though it might seem prosaic, is maintaining normal temperature during and after resuscitation. Temperature on admission from a birth location to a neonatal unit or postnatal ward is a strong predictor of both mortality and morbidity. And in fact, for an ILCOR systematic review in 2015, the effect on mortality was estimated as an increased risk of death of at least 28% for each degree below 36.5 body temperature on admission. And there was also evidence of a dose-dependent effect size. But despite previous strong ILCOR and WHO recommendations, hypothermia remains quite serious and prevalent in both preterm and term infants and in high, middle and low income countries. And just in the panel on the right, I've put examples of the rates of hypothermia or cold stress in late preterm and term infants in the control groups of some of the recent randomized controlled trials that we have assessed. And so you can see the rates there as being, you know, anywhere from about 45 to 75% of all newborns. So a serious problem that we could improve outcomes, I think, if we could correct that. So our focus on hypothermia includes that we completed a systematic review in 2022 for maintaining normal temperature in late preterm and term infants. We found mostly low certainty evidence, but there was evidence to that increasing ambient temperatures where babies are born to around 25 degrees Celsius. It reduces the rates of hypothermia. We found evidence for skin-to-skin care where it's feasible to perform that skin-to-skin care with either the baby's mother or father, depending on who's available. We found evidence that a plastic bag or wrap, similar to the approach that we use in preterm infants, may be useful in situations where skin-to-skin care is not feasible, such as when the baby is needing some form of resuscitation or when the mother's too ill. And there is possibly a role for combining those interventions, although some concern there about the possibility that that a plastic bag or wrap may take away some of the advantages of skin-to-skin care, such as its contribution to establishing a normal neonatal microbiome and establishing mother-infant bonding. We found insufficient evidence for most interventions in babies who were needing resuscitation because in many cases they were deliberately included from the trials.
Helen, we're really almost out of time.
Up against time?
Yeah. If you could just give us sort of summarize in about 30 seconds, and we can get our last speaker up. Yeah, sorry.
Yes, absolutely. We've also got other trials. So we're doing a review in preterm infants. We're studying the rate of rewarming after unintended hypothermia, and also looking at the role of therapeutic hypothermia in low and middle income countries. It's a well-established treatment in high resource settings. We've been looking at suctioning of the airway. And also a number of other reviews, including the use of supraglottic airways instead of face masks, CPAP for term respiratory distress, respiratory function monitors and ECG to guide newborn resuscitation, and tactile stimulation at the beginning of the process. Glucose management, exhaled CO2 monitoring, various cardiac compression techniques, various aspects of assisted ventilation, and the methods and timing of artificial surfactant delivery. Finally, I'd just say that another important initiative this year is we're hoping to publish later on this year a neonatal version of the Utstein consensus for registering and reporting resuscitation interventions and outcomes. And that process is led by Liz Foglia from the Children's Hospital of Philadelphia. So that's it. Thank you very much.
All right, thank you, Helen. And in the interest of time, we started about 10 or 15 minutes late, so we're going to go over our time limit. If people do have to go, I think it's fine, but we're going to go ahead with our first aid presentation as well, and I encourage you to stay and listen to Therese Jarve. He's going to give us an update from the First Aid Task Force.
Yes. Okay. Thank you for staying, and sorry for taking time of your lunch break. Can we get the presentation up? Yeah. Okay, that's back. So finally, we're going to talk about what you do first, the first aid.
We should have gone first.
Yeah, I should have gone first, but now it's the last time. But stay, thank you for staying. So this is my conflict of interests. I think many of you have a first aid kit, a OOCH kit at home. And it's quite good to know what's going to be in it. Because you don't want to be this person doing the things you can read in papers you shouldn't do, because people, your neighbors, your family might know that you're in a congress on resuscitation. So this is the first topic that's really hot for us, and that's cooling of burns. Last guideline, we wrote that you should cool for at least 10 minutes if you have a burn. This led to letters to editors that this was totally wrong, and a lot of issues with this. So we in the task force had to go back to the drawing table and look at what's actually out there and what do we know about cooling of burns. And we know a lot of stuff, and we agree with the burn experts that we know that it relieves pain, it reduces burn depth, running water is much better than products out there, and we know that clinicians worry about hypothermia. And we also know that people tend to cool much shorter than durations prescribed in the guidelines. So therefore, we tended to do a new systematic review, and we thought that this is only the duration we actually argue about, so let's do a systematic review. We looked at 10 minutes versus 20 minutes. And this is what we found, actually, when we plotted the burn size. And you look at the larger burns, they were actually cool for longer, and maybe this is what's happening out there. Because if you go to yourself, when do you stop cooling a burn? Do you set a timer and wait for the timer? Most of us might actually cool until the pain stops. So this is a problem because we know that cooling actually reduces depth of the burn, not size. So it's a problem when we look at guidelines and the evidence out there. So what did we end up with? We changed the guideline, so now you should cool for 20 minutes. And this is based on that we don't have any evidence for any durations, and we know that people cool very short. Most only cool for 5 minutes. Another problem with this is that most of the burns actually occur in settings where they don't have running water. They use open fires to cook. And this is about implementation. How will we do it? And we have a session tomorrow, and that will be about implementation. Please join that, and we will give examples on how to implement this in, for example, South Africa. Yeah, so the final part of this recommendation is use cling wrap, and this is actually what you should put in your first aid kit if you want to buy a new stuff for this summer, because it will be helpful for other things as well. If you lose a tooth. When I was a child, I was taught to put them in milk. Don't do that. Cling wrap is much better and easy to carry along. Okay, let's continue the summer team. So summer camps is coming up, a lot of football is going on. And of course, we have a good football player in Sweden. He plays in other countries as well, Zlatan Ibrahimovic. So, this is from when he was playing. In Milan, he played for 28 minutes, and then he had an ankle injury. What should ILCOR do? Of course, we do a systematic review. Should we do a compression wrap or not? So actually the review found that for all outcomes we looked at, and you see them there, it has no effect compared to not doing a compression wrap. And again, those of you who do first aid courses, you know how much time you spend on wrapping it. Oh, it's too loose, it's too hard, redo it, and they take it off, and again. So this is waste of time in first aid education. This is what I'm saying. But let's go back to Zlatan. He has knee problems, but he actually points against his foot. Should we do a compression wrap on him? Yeah, there's actually one study saying that sports athletes, not me, not you, but him, if they have it, it's actually better. They come back to work quicker. So what are we going to do in guidelines now? I'm going to show you the Swedish guidelines. This is what we wrote in Swedish guidelines. Wrap the foot from toes to ankle if you wish and is trained for it. Yeah, exactly. What is going on out there? And this is the question for first aid. You really need to understand what's going on in my settings. What are the important topics? Are we doing the first aid training for the sports athlete team or the kindergarten or something else? Then you can cherry pick what you need to include so it makes relevant. Okay, we are soon going to go for recovery for summer. We're going to have some recovery activities, and we are on a resuscitation congress. I just want to highlight the final thing we actually have done a systematic review on, and that is recovery position. There are a lot of different positions, and we didn't find any evidence for any of them. None are better than the other, so our advice is just keep doing what you're doing, but do not miss to reassess the airway and signs of life. That is really important. We really want to stress that when you teach this in your classes. And I know we're now going to go for a break. It's been a long time since we went to conferences and congresses, so I just have to warn you, and some of you might have problems with going up too quick. And we got some evidence-based methods to really prevent syncope in first aid. So do this, please. Don't have syncope on the way to the break. And I think I'll stop there. Join the session tomorrow. Thank you.
Good job.
Thanks, Teresa, for this really quick wrap-up. Only one question, because then we close it. Isn't this medical treatment for the professional football trainers? And is this different, what I think, from first aid on a camp?
Yes. Yes, this is very upsetting that we treat persons differently, but the problem is not we treating them differently, they need different stuff. And we should always give them what they need. So we need to understand it better. Okay.
Individualized first aid.
Exactly.
Okay. We're running out of time. I thank all of the speakers for the presentations. I hope you got an insight what ILCOR is doing, for what are we there, and a huge and a big thanks if you are contributing. So if you're interested, look out. If there are positions open, send in your questions and start. We want to work with you. Thanks.
Yeah. Great job. That was really good.